man show, one man show decision. We have to make it with a meeting with other colleagues, or we have to make systemic approach, and teamwork also for the surgery is mandatory. Managing the risk, it's important preoperative to evaluate the patient and to reach the patient to the best status that we can do for the surgery. Surgical technique, minimal invasive technique, always is the best to minimize the complications. Post-operative care, early mobilization, monitoring of the complications, and as Dr. Imad said, if you say it, do it. If you say the complication, don't delay, make it directly. But sometimes everything what we are trying to do, we put our plan, we do everything well, but the complication will happen, as we can see in this space travel challengers happened, but they did everything, try to make the plan for everything, but when the complication will happen, it may be a disaster, as we can see in this small video. I chose this video because really when you remember this kind of the disaster that can happen in ours, also in our theaters, that the problems could be like this. So we have to think, where is our problem? Is there any technical problem? We ignore the checklist, human error, failure in the CRM, or automation. So prevention of the wrong level of the surgery is very important. So we are doing the surgery every day. Sometimes we are not taking care of the level of the surgery. We have to make it very clearly before the surgery in the meeting to put the indication of the level. Intraoperative, we have in the team time out, we have to speak that and involve all the people in the room about the level of the surgery. Intraoperative marking with good imaging, it is very important to put the correct level. If we have a doubt, we have to ask another doctor or another consultation of radiologist. The protocol for the infection prophylaxis, I think all of us are doing that. Sometimes intraoperative we have to do only small things, just turn the light on, it will change all the things in the theater. Just turn your microscope, it will change your view, and it will make the things too much better and to avoid the complication. Using the new techniques, robotics, navigation, and augmented reality, it will help too much to avoid the complications and to reduce the rate of the complication. Minimal invasive surgery. And there is two studies showing the difference between hand-free instrumentation and robotic screw instrumentation. All the studies shows that the new technique is too much better to avoid the complication for the instrumentation. I will show two cases we have done the last year. 26-year-old patients with congenital kyphoscoliosis, severe spinal canal stenosis, back pain, and radiculopathy with claudication, weakness in her left leg. We can see here the severity of the kyphosis and the scoliosis, and the kyphosis is more than 90 degrees, hyperlordosis in the lumbar area, and this video shows us how much and severe is the spinal canal compressed at the end of the cones. This is the patient before the surgery. We can see very big hump, and this is after starting doing our screws in the correct way, positioning our screws correctly. We can see intraoperative, the kyphosis is more than 90 degrees. Started doing our very nice kind work, not like the neurosurgeons, but we are more aggressive a little bit, and we are trying to avoid to damage the nerves as much as we can. We make the vertebral column resection, and after doing the correction, and the spinal cord was completely free. The patient after the surgery too much better than before. This is as one more time intraoperative picture with using vancomycin. Everything went well. The correction very nice. Neuromonitoring during the surgery all the time. It was nice, no problem. Like the baseline, the patient woke up, she couldn't move her legs. I don't have any explanation. I don't know what happened, but we are very aggressive. The condition is very bad. The case is very complicated. The patient started after 6 weeks moving her legs, and after 3 months she started walking up, but still she has weakness. Sensory is too much better, but she still has some deficits. Another case, 15-year-old walking patient, no normal neurology, idiopathic thoracolumbar scoliosis. With we did scoliosis correction and fusion with multiple ponti osteotomy from TH2 to L4 with severe. She has severe deformity. This is the pictures before and after the surgery. Very nice work. We are happy. Intraoperative, we started to make the correction. I started to put the rod from the right side. We have lost the signal from the left side completely. So vastus lateralis tibial anterior, tibialis anterior was completely lost. So we tried everything. I opened the screws, reduced the correction, make washing. We checked everything from the anesthesia side, from neuro monitoring side, the cables, the machine, everything was okay. Tried to wait a little bit without doing any maneuver. More than half an hour, still the same thing. We have lost the MAB and also the SSAB. So tried again. I checked all the screws one by one. I have doubt about one of the screws in TH8. I removed the screws completely. I have done decompression in all the levels. Very important to know, to try to do everything you can do, and then wait a little bit. And after a while, we received the signal was coming. So after more than half an hour, tried again to make the correction. Slowly, after the decompression, everything went well, and as I showed you, the signal became like the baseline. And this is the patient directly after the surgery. She started, on the left side, she started moving her legs after the surgery. I was shocked a little bit, but she moves at the end. So, and after 3 months, she was completely good and nothing, no neurological deficits. What we know about that, typically 50% decrease in amplitude and 10% increase in latency are considered significant when it's happened in the theater. Treated immediately and subsequently, most incidences are reversible. We have to go to Swiss cheese model to check the error, the staff, anesthesia side, surgeon, and intraoperative neuromonitoring staff. We have to check first our own pulse to continue thinking and doing the surgery, and to go for troubleshooting algorithm. It is very important to have this kind of mentality and algorithm in our OR. So first of all, we have to define the source of the problem, technical problem, surgical problem, anesthesia. Before good treatment, we have to put the diagnosis. There is intraoperative neuromonitoring staff agenda. We have to check all the things, machine, cables, verifying signals, drags from the anesthesia, EE depth, and communicate each running SSAB and MAB. So from the surgeon side, we have to check all the screws, especially what we did in the last 15 minutes, the correction if we are doing deformity, and we have to examine the osteotomy, the site of the osteotomy. If there is any compression in the MRI, we have to check it again and try to do our job from the surgical side. So from the anesthesia side, thank you. If there is great change in the pH, if there is hypocarbia, hypoxia, we have to get the lines together, communicate with all the team together, and after that, 90% of the problems will be solved following structural algorithm. And this is very nice paper 2022 published, and showing how we can do that preoperative and intraoperative. In conclusion, minimizing the neurologic deficits in spinal surgery is priority in every spine surgeon. Surgeon understanding and managing the complication is the key of reducing the complication. Using of new technology to learn new method. It's very important to reduce the complications. and we have to learn from our own mistakes. So always, if you always do what you have always done, you always get what you've always got. This is a very nice talk from Henry Ford. Thank you so much.